Your program says that the three speakers will be Geraldine Leader, myself, Nigel Paneth, and Orla Flanagan. Unfortunately, Orla had a family health problem that she had to address and had to cancel, and we learned this last night. So at 8 p.m. last night, I asked Dr. Keith English if he might possibly help us out, and without a moment's hesitation, knowing that he was to speak in about 15 hours, he immediately agreed. And even though this topic is not actually entirely in his field of expertise, but as I'll explain later when I introduce Keith, you'll understand why it is that he can just step up to the plate and do something unexpected at the last moment, because he's done that before. So our first speaker today, as she has told me herself, needs no introduction. Geraldine Leader.
Don't introduce me.
But I will say a couple of things about Geraldine, just to say, in addition to being an inspiring colleague to work with and help plan this great event, that she is a very serious researcher into autism and other neurodevelopmental disabilities. But more than that, she has taken her skills in management and organization to create institutions that further the research area and the practice area we're interested in, having founded the Irish Center for Autism and Neurodevelopment, which has the lovely acronym of ICAN. That's a good acronym. And now, since 2017, she is Director of Research for DOCTRID. So, and she's going to talk today about the very interesting topic of gastrointestinal symptoms in autism spectrum disorder.
Okay, so just before I start, I'm going to talk today about what I call the bigger issues in autism, and I suppose to increase our understanding of autism. But before I came to this work, I would have spent my earlier career working very closely in terms of the treatment of autism, early intervention, and from the research perspective, how can we put in place the skills that are missing and decrease the ones that are problematic. So I come to this research with a very strong background in intervention research. And during that time, we would have set up a program to train practitioners. So 10, 15 years ago, there was a dearth of highly skilled practitioners. So I think we've come a long way in training practitioners and getting them out there in the community to provide really great and high quality early intervention. So my talk today, it's going to start very brief introduction to autism spectrum disorder, because of course most of the audience is very familiar with it, and then I'm going to go on and talk about an issue I became very interested in, that of co-occurring disorders. And a co-occurring disorder is when a child or an adult on the autism spectrum gets diagnosed with an additional diagnosis. So I'm going to talk a little bit about that, and then I'm going to go on and talk about gastrointestinal symptoms, because our work in co-occurring disorders led us to studying gastro issues. And then finally, I'm going to finish off with introducing a project that's funded by the EU that we recently received funding from. So I'm going to trace through a little bit of a story that got us to this project. Okay. So for most of us, this needs no introduction, this slide. Autism spectrum disorder in the most recent DSM-5 now has two core areas of deficit. So that is that of communication, social interaction, and the presence of restricted interests and fixed interests and behaviours. So one of the first things I would say about autism is, for me, it has long been a fascinating area to study, because obviously it's a spectrum disorder. I think that's what makes it so fascinating, the heterogeneity of it, that each individual is so different, ranging from mild on the spectrum to the more challenged. Then we have language issues within autism, again from really good language skills to the other end of the spectrum with maybe non-verbal. Then I suppose from the practitioner perspective, a big challenge within this field would be treating the behaviours. Again, that can reach from mild to severe to quite severe challenging behaviour when you're developing interventions to this population. And then the other point to bear in mind is that it's a developmental delay. So these issues become apparent in the first 2 years of life. Okay, so in our EU grant applications, we're now very fond of saying that ASD is a global societal challenge, and it is without a doubt. And this graph really brings that home. So we really started measuring prevalence back in the 70s, and there has been a 35-fold increase since the earliest epidemiological studies. So this graph is one you're all probably very familiar with, and it's the one from the CDC in the States, and their most recent reporting that we're now at 1 in 59. So quite a striking graph and quite a striking statistic. So I just included this slide very briefly because I'm a little bit of a history buff. It's like what I like to listen to history podcasts in my spare time. And Kanner was the scientist who's actually a psychiatrist who first identified autism back in 1943. So this timeline is just to demonstrate after Kanner's discovery, really our understanding of autism really didn't advance very much because we had the dreadful refrigerator mom theory that dominated the field for a while, and looking back on it now, you could say we have come a long way. But it really wasn't until the 1980s that we started to really get to understand what is causing to increase our understanding, in that a lot of work has been done on the genetics of autism. So we're now aware that autism has quite a strong heritability factor. And now we understand that autism is a combination of genes and environment. And then there were very influential twin studies, and these twin studies also helped to increase our understanding of autism. And those twin studies showed us that in identical twins, if one twin is diagnosed, the other has a 76% chance of getting a diagnosis. With fraternal twins, with same sex, it's 36, and it reduces down to 18 for a boy to girl. Okay, so moving on from our understanding of autism, in the blue we have the core deficits of autism, okay, the diagnostic criteria. And I and my lab, about 7 or 8 years ago, I became fascinated with this. And what this is showing us is you've got your autism, but then you've got all the other stuff that is also going on. Right? So that's just like, for example, you might have feeding disorders. We heard yesterday, we're talking about children, food selectivity, how challenged that is. We talked yesterday about sleep disorders, insomnia. We have mood disorders, we have anxiety disorders, we have OCD, we have ADHD. Then we have the whole sphere of behavioural problems, tantrums, aggression, self-injury, and so on. So when you look at this graph from the perspective of intervention, for example, so let's just say you're trying to teach a child social skills. If that child has an anxiety disorder, that makes that very difficult, because you've got to go first and treat the anxiety disorder before you can start on your social skills. Similarly, if you have a child with serious aggression, challenging behaviour, it would be near impossible to deliver any type of early intervention. So we felt that it was really important to start researching these topics, because they really complicate the clinical picture. So I suppose when we started this line of research, co-occurring disorders or comorbidity was a relatively new avenue of research. There really wasn't a lot out there at that time. It has now accelerated a lot since then. And it was very clear to us, even before we started reading the research or doing research, is that comorbidity certainly affects outcomes. And then the other thing we were noticing is that they can be underdiagnosed. Now, I have to say there are fabulous paediatricians in this audience. This doesn't apply to them, but just generally in the literature we were seeing that they were being underdiagnosed, and the reason for this was diagnostic overshadowing. So the child might be showing signs of anxiety, oh, it's the autism. So now I'm talking a few years ago, they're much better recognised now. Like for example, you can get a dual diagnosis of ADHD and autism now, where previously that wasn't possible. So we then began to delve into this more, in that our first study that we published was we just simply wanted to look at what are the rates of co-occurring disorders with children that have an autism diagnosis. So in this study, we looked at 89 children, and we administered screening tools for a whole range of comorbidities. And what came out, dealing with the lower ones first, we found 10% epilepsy, 18% ADHD, 15% of anxiety. But what really surprised us, and remember this is back in 2013, 80% had GI issues and 80% had sleep problems. So we were really surprised by that. We really weren't expecting it. We didn't really think the prevalence would be that high. So that, I suppose, then prompted us to explore some more. So what are GI symptoms? So GI symptoms can range from nausea, bloating, abdominal pain, constipation, diarrhea, reflux. So 80% of our sample had at least one of these symptoms. So why is it important to study GI symptoms? We felt it was important to explore some more, do more research on this, because obviously there's the obvious pain and discomfort. You know, what if a child is non-verbal? Is that GI issue being picked up? And it is also, and it's very clear from the literature, that the kids that have GI issues, their behaviour problems are worse. Okay, so it's quite obvious why that would be the case. And therefore, if these children have behavioural issues, it's difficult for them to access education. So then the following year, we published a systematic review, a review of the literature to bring all this together and to highlight the important areas. And the important areas are where the areas at which GI impact or challenging behaviour, language, severity, comorbid psychopathology, sleep, and sensory issues. So then 2 years later, we followed the children from the original study. So we were really asking a very simple question: had the GI issues persisted? So we repeated the study with the GI symptoms, and they had persisted in 84% of our sample, and 20% had acquired them. So it wasn't an issue that was going away. So then we did more analysis, and what we found from our children that had the GI issues, these were the kids, compared to the children that don't have GI issues, had sleep problems and they had behavioural problems. And we found this relationship over and over again. So this graph really is why we felt it was so important to study the GI issues. So that work then led us to be invited to be part of a consortium. And this consortium just recently received funding from the EU of 14.2 million to conduct a longitudinal study of birth of the development of autism, with a special emphasis on GI issues. So we're absolutely thrilled to be part of this consortium. There are 16 partners, and we now are currently the only project in the EU in autism. And with the success rates down at 2%, We're still pinching ourselves that we could be this lucky. But I have to say, we didn't get lucky the first time. You know, we got rejected and rejected, but you got to dust yourself down and go back. Okay, so this is GIMA. We call ourselves GIMA Ireland. So this is Team GIMA. Dr. Orla Flanagan, who can't be with us, is a co-investigator, as is Lokesh Joshi, who you met yesterday, our VP for Research. And then Stephen Cunningham, who works in Lokesh's lab, will be managing our biobank. And then the observation and intervention study is being managed by Arlene, Sophie, Katie and Leanne. So that's the team which we've just very recently put in place. So as I said, this is a 5-year EU-funded project. It's multi-centre, it's prospective, it's longitudinal and it's observational. So this is really exciting for us because we're going to be following the development of autism from birth. And this hasn't been done before because obviously it's hugely expensive to do this type of research. Any type of longitudinal research is extremely expensive. So in this study, we're going to be really looking at 3 main areas. We're going to be looking at environmental risk factors. As I said at the beginning, we know a lot now in terms of the genetics of autism. We know much less about environmental risk factors. And in the literature, we're only now starting to look at environmental risk. So this is a wonderful opportunity for us to track all the environmental risk factors, starting prenatally. We then are going to be gathering lots of psychological data. So we're going to be administering the ADOS toddler every 6 months. And finally, we are going to be building a biobank, and a central emphasis of the project is GI issues. So we will be gathering stool samples and we will be looking at changes in the microbiome as the child ages. Okay, so as I said, we're the first large-scale project to observe ASD from birth. We're going to be recruiting 600 infants across 3 recruitment sites. So there's a potential then from that work, we might discover new early signs of autism. It might lead to earlier diagnosis of autism. And which I think is really important, it will allow us to identify the prenatal, the perinatal and postnatal risk across 600 infants. So we're one of 3 recruitment sites in the grant. So we're operating from here, but we hope to be reaching out nationally and recruiting nationally in Ireland. There's a second recruitment site in Italy, in Salerno, and then our 3rd recruitment site is MGH in Boston. Okay. So just very briefly on the GI side of the house. Here in ICANN, we're going to be primarily concerned with the observational trial and the intervention trial. But just very briefly, the whole issue of the gut-brain axis, we aren't the first area to start looking at GI issues in terms of understanding why a condition is diagnosed and the treatment of it. Schizophrenia is looking at it, epilepsy is looking at it, Parkinson's disease is looking at it. So what evidence do we have in relation to GI in autism? We know that the microbiome in autism is different from controls. There is some evidence to show that as a child develops autism symptoms, there are changes in the GI, in the microbiome, and then there's also evidence that a change in diet sometimes can show a reduction in autism symptoms. So there is, like, this isn't a hypothesis we have dreamed up. There is lots of evidence in the literature, but of course, right now, that's all correlational. It's not causational. Okay. So there's going to be a lot going on in terms of analysing what's going on in the microbiome in the grant, in the consortium. As I said, we are primarily concerned here with operationalising the observational and the intervention trial. So, after this conference, next week, we hope to launch the project, and our task is to recruit 200 families in Ireland. So, as I said, first of all, we are recruiting from an at-risk population. So we're looking for families that already have a child with autism. Then we're looking to recruit the sibling as our participant. So we're looking to recruit siblings who are 6 months or younger. And we'll also be delighted to recruit pregnant mums. Okay. So you might ask, why would a family want to be part of this study? Well, I think we're very much aware of all the stuff we talked about in terms of families with autism, in terms of stress and burden and sleep deprivation and so on. But I met a mum a few weeks ago, and the child she had with autism was the eldest. She then had another child, and the participant we will be recruiting was 2 months old. And she was so motivated to be part of this study because she said that she went through torture with her second child, just wondering, will my child get autism? Maybe she will, maybe she won't. So what we can offer for parents, because we're very, very aware of the burden and their time, is that we can give them information. We'll be administering ADOS every 6 months. Once the first signs become obvious, they will have that information. And at the end of the day, information is power. So we expect between 10 to 20% of our sample will develop autism. They will have that information as early as possible. And obviously they don't have to go through the long waiting lists that otherwise they may have to. But on the other hand, the other 80% will have peace of mind very early. So I'm hoping that will be a very motivating factor for families to participate in the study. So we're going to be doing a lot of data collection and a lot of rich information for research. The ADOS, as I said, the ADOS toddler is going to be administered starting at 12 months and then every subsequent 6 months. And we'll be doing this up to 36 months. Then parents at home online are going to give us lots of information. We're going to be tracking language development, adaptive behaviour development, and then because of the GI issues that we're interested in, we're going to be asking also for them to keep food diaries. So we will have lots of rich information on adaptive behaviour, behavioural issues, are they occurring, how is language developing, and of course the core autism symptoms, the presence or not the presence of them. As I said, also it's going to give us a rich data set, and I think this is a real research priority for this grant, is the environmental factors. As I said, we have lots of information on the genetics. We're still at a little bit of loss on the environmental risk. So that's going to be very exciting. So then, as I mentioned, the other side of the house, the biological side of the house, we here will be building a biobank, and that will give us, again, it will be an incredible resource going forward, I think, for future research as well as this project. And we will be getting stool samples every 6 months from parents, and that will allow us to track any changes as they occur, or if they occur, in the microbiome. And the first 3 years of this study are observational. Then year 4 and year 5 are intervention. So if a child develops autism, they will be invited to remain with us in the study. And what we're looking towards is, given what went on in the gut, any changes in the gut, we're really looking towards personalised medicine in terms of designing a diet, a special diet for that child, personalised to that child based on changes in their gut. And it could be an elimination diet, like taking out something like gluten, for example. We don't know if that's going to be the case. This will all be determined by the interventions, or by the observational study. So obviously, we don't have the protocol yet for the intervention study. It will be determined by what we find. But in broad strokes, what we're looking towards is potentially potentially. Personalized diet, that potentially, again, this all comes with health warnings, that may reduce autism symptoms. So that's the ambition, that's the dream. Okay, so that's just a graph of our data collection. So then just to, I'm not sure how I'm doing on time. Oh, 1 minute, excellent. Okay, so the ambition of the project is identifying environmental risk, first and foremost, identifying biomarkers, investigating the microbiome, potentially delivering a special diet that may reduce autism symptoms, and finally having a rich data set for this research and future research in terms of psychological, environmental, and biological. So that's it. And just very finally, if any practitioners, if anybody in the room knows of parents, families that have a child with autism and a young sibling that may be interested in contacting us, you can go on our webpage, www.icanautism.ie, and leave your information, or the family can leave their information, or they can email me directly. So thank you very much for listening.
So I'm Nigel Paneth, and I'm a pediatrician and epidemiologist at Michigan State University, and I am co-director with Mike of the Center for Research in Autism, Intellectual, and Neurodevelopmental Disabilities. And I came in later than Mike, a couple of years after it was founded, and I, to some extent, represent the N word, neuro, because I've been interested in the motor disorders, cerebral palsy, which is a major part of our developmental disorders profile. This talk will be posted on my department website, which I'm sorry I neglected to put on this slide, but if you just Google my name and Michigan State, you'll find it there next week, and you can download it and use it as you wish. So today I'm going to talk about prevention, and this theme was set up a little bit by Mary McCarran in her first talk yesterday when she said, the diagnosis and management and treatment are very compelling. The person with the condition is in front of you, they need help. And it's easy for that to take away attention from preventing the disorder in the first place, which sometimes gets a little bit less attention, we think, than it should. And the second theme was emphasized by my fellow Nigel knew about this morning, and we knew Nigels were rare enough, we have to stick together. So he said we should emphasize the impact of what we do, the impact, the changes that occur in the population. It's not just good enough to do research, perhaps not even good enough to just do a trial and show that it works, but to take it a step further and see if we can't get it out into the community, whatever it is, be it prevention or treatment. And I'm going to the prevention opportunities I'm going to talk about today. Pretty much all we know have evidence behind them that they are making an impact, and yet they could make a greater impact if we pushed a little harder. So I think this will be it. So I begin to give you a little picture of the profile of developmental disabilities numerically, which is, we have a bumper, we epidemiologists have a bumper sticker. It says epidemiologists count, because that's what we do. And so we count things. And I've listed 6 of the major developmental disabilities we are concerned with. Severe intellectual disability, we've heard a lot about, occurs in about 3 to 5 per 1,000 live births. Cerebral palsy, which is listed 4th in this size, also at that same rough level of prevalence, fairly rare, 1.5 to 4 per 1,000 live births. So those 2 conditions, which are severe and really interfere with functioning, are quite rare. And then we have 2 other conditions, mild intellectual disability and autism spectrum disorders, which affect between 1.5% of the population, depending on the count. And these are figures for the US, but I think these figures are quite similar in Northern and Western Europe. And then we have 2 conditions that are rather common. Attention deficit hyperactivity disorder, which affects 5 to 7% of school-age children, and learning disabilities, which is up to 10% of the population. So if you take them all together, allowing for overlap among them, perhaps 15 to 20% of the child population is affected by a developmental disability. It's not a trivial number, and obviously the more common are less severe and the rarer are more severe, but we certainly have something that we have to address. And there's been some, I want to emphasize just before I get into the prevention, the recent, I just mentioned the abbreviations. I'll use, most people know these, but just to be safe. And I'm going to talk a little bit about a change that sometimes goes unnoticed because it's occurred over the last 50 or 60 years, which is the greater survival of very tiny babies, which is making an impact on the picture we see of developmental disabilities in countries that have access to intensive care. And we talk about extremely premature babies born before the 28th week, LGANs, extremely low gestational age newborns, and extremely low birth weight babies under 1,000 grams at birth. And the improved survival is really one of the changes. In 1960, which is a long time ago, but it's within the lifespan of some people in this room, including yours truly, there were perhaps in the entire United States 200 one-year-olds who had weighed less than 1,000 grams at birth. And in recent years, we have more than 16,000 children who had been less than 1,000 grams at birth. This is a whole entirely new population that essentially did not exist prior to the development of newborn intensive care in Western countries. And so we have to be aware of them, because the wonderful thing is we save their lives. We haven't gotten as clever at saving their brains. We wish we could, but we certainly need to address that. So here are the figures of, for example, risk of cerebral palsy by gestational week at birth. In the less than 28, 27, 28, 29 weeks gestation, we're talking about nearly a 10% risk of cerebral palsy, which is about 50 times the risk for a term-born infant. And then severe intellectual disabilities found in 5 to 8% of extremely low gestational age, extremely low birth weight. Hearing loss and vision loss, which I didn't mention in our overall picture, but are often considered developmental disabilities along with epilepsy and autism spectrum disorder, I think at least 5%. There's a very high risk for autism spectrum disorder in very premature infants. In one study we've done, babies born at the real margins of viability before the 26th week have about a 15% risk of autism. That approaches the risk for a sibling of a child with, and these were, by the way, diagnosed in the proper way, ADOS, ADIR, not just, just mentioned in a medical record. So one or more of the above is about 20% of these severe disorders. I haven't mentioned the milder ones, but the milder ones are also common. Probably 15 to 20% of these babies have ADHD, 30% have mild intellectual disability, about a half get held back or need special education. So this population is one part of the epidemiologic profile that's worth thinking about. Now, so let me get into the meat of the talk, which is there are, in fact, quite a few ways to prevent developmental disabilities. And I find that in my talking to people who work with the developmentally disabled or who work in neuroscience, they are sometimes not fully aware of the fact that we can do a lot to prevent. And I'd like to emphasize these, because the more we can do to get our activities out there, the word out there, the better we will be off. I'm going to list 8 different ways to prevent developmental disabilities. And they come at different times, because we can intervene before pregnancy even starts. I'll mention 2 interventions. In pregnancy, in labor, actually, and immediately after birth, and finally, in early childhood. So let me give you an overview of these, and then I'll take them one by one. So what can we do before pregnancy? Well, rubella, which is a mild illness, German measles, a mild illness in most people, has a terrible attraction to the fetus and particularly to the fetal brain, and can do devastating damage. And all it takes to prevent this is to have a population immune to the rubella virus through immunization before pregnancy occurs. Once pregnancy has occurred, it's too late to try to immunize against rubella. And the same is true of folic acid, whose deficiency leads to neural tube defects, which are associated with intellectual disability and cerebral palsy. No woman should enter a pregnancy in Ireland or in the United States or anywhere else in the world susceptible to the rubella virus, and with an insufficient supply of folic acid in her diet. Those are such simple things to do. Folic acid retail costs less than 1 penny a day. Okay, rubella immunization is also not expensive. During pregnancy, prenatal screening is widely used around the world. People have different views of it. I'll just mention it. I'm making no judgments about it. I'm just saying it. I would agree that with many people that a gene doesn't give a full prognosis. So one has to be thoughtful about this. Iodine deficiency in many parts of the globe is the leading cause of intellectual disability. The leading cause, iodine deficiency. And that's simply remediable by providing iodine. This occurs in parts of the world, Andes, the Himalayas, Papua New Guinea, some parts of central China, which are iodine deplete in the soil, and the soil doesn't provide enough iodine. This leads to hypothyroidism in the mother. If she sufficiently has enough thyroid just to get pregnant, which sometimes she wouldn't if she had too little thyroid, women with goiters, she will not have enough thyroid to sustain brain development. Thyroid is the single most important brain developing hormone in utero, and probably in the first year of life too. So you have to take care of that. In labor, as I show you, we now know from very good studies that magnesium sulfate administered in babies who are in labor, to mothers in labor, actually reduces the risk of cerebral palsy in offspring. I'll show you the details in a moment. People, I'm sure in this room, know about newborn genetic screening, the two particular interventions that matter to intellectual development, because some of the things we screen for have to do with illness in the newborn period, are phenylketonuria, in which you treat with a diet, and hypothyroidism, which you treat with thyroid hormone. Those are easily diagnosable at birth and easily remediable without great expense. And another intervention that's very exciting is that babies who've had a very bad birth experience with birth asphyxia, acidosis, difficulty breathing, if you cool them, their head or their bodies, for 3 days, 72 hours, just drop their body temperature by 2 degrees, excitingly enough, you reduce the risk of cerebral palsy by at least a quarter. I'll show you the data in a moment. And finally, this may be a little closer to your areas of comfort, the interventions early in life with stimulation programs, early education, pre-kindergarten involvement, actually have substantial benefits shown by very good trials in terms of the cognitive performance, and even more so in the behavioral performance that allows children to do well in school and not drop out. So these are 8 ways. And by the way, all of these, pretty much all of them, maybe even head or body cooling, maybe not so much, are relatively inexpensive. And there's an interesting rule I found recently in medicine that if something is very expensive and marginally effective, you will see ads on it on TV and radio. You'll hear a lot about it because Big Pharma is very interested in it. But if something is really cheap but still effective, we don't pay attention. There's so many things we could do simply. So newborn genetic screening, believe it or not, has been in existence for nearly a century, since the Swedish pediatrician Folling discovered that some babies with with intellectual disability have phenylketones in their urine because they have a genetic defect, and phenylalanine in the brain in utero and in early life is very damaging. And all you have to do is change the diet. We've been doing this for many, many years. And the second one is the thyroid hormone. This is a little different from the iodine deficiency. This is a baby's born without a thyroid gland or with a deficient thyroid gland. If they don't get thyroid hormone in the first months of life, they are also condemned to having a lesser IQ than they could, and we can treat that very easily. And prenatal diagnosis has been reviewed many times. We look for neural tube defects, chromosomal abnormalities, and other conditions that may lead to severe ID. And both of these, now I'm organizing this by what they prevent, are really trying to address severe intellectual disability. The intervention to prevent mild intellectual disability, to raise cognitive performance, is really the enhanced education, or even sometimes home visiting, to work with mothers on infant and child stimulation. It's remarkable how modest the intervention sometimes is that changes things. A good review from a few years ago by the Ramies, who've done a lot of work in this area in North Carolina, But I also like to point to the work of Sally Grantham McGregor in Jamaica, who I think has done the most interesting work on relatively minor interventions in families with fewer resources that change the trajectory. I was in Jamaica hearing about some of this research, and they're actually, if you can believe this, second-generation effects. That is to say, children who got these extra programs, their children later, 20, 30 years later, benefited as well. It's extraordinary. So these things are very important to do. This is a recent review in Science on these early educational interventions, and the initial effects show about a half a standard deviation of raise in IQ, and these are the best designs with the best interventions show a slightly stronger effects, but even many years later you can still pick up effects that are at least as strong, a fifth of a standard deviation, about the same level as low-level lead. So low-level lead affects the brain probably about the same as lack of early stimulation and cognitive improvements. Very early, starting school early, the Jamaicans are really on top of this. I was talking to them, I've been involved with some of their work. They said, every school begins at 3 in Jamaica. We've got to do something about it and make it earlier. There have been 2 interventions to prevent cerebral palsy, a particular interest of mine. Fairly recently, this has been developed. I mentioned magnesium sulfate in labor. Several trials confirm a 30 to 35% reduction in the risk of CP in infants born before the 32nd week of gestation. And here's a systematic review by Lex Doyle and others from Australia in obstetrics and gynecology from 2009. I'll show you some of the data on the trials in a moment. And head or body cooling, again, a very consistent body of trial work showing that you can reduce the risk of CP by 25%. Also, by the way, you reduce the death rate by cooling newborns who have had an episode of hypoxic ischemic encephalopathy, namely, which is another way of saying they looked like their brain has been injured by the process of birth. So here's some odds ratios relating magnesium and cerebral palsy. I was one of many skeptics in the 1990s when 2 case control studies came out saying that premature babies whose mothers had happened to get magnesium for a variety of reasons that magnesium was used for had 1/10 the risk of cerebral palsy. It was a too good to be true kind of result, so we were, come on, what's going on? Something wrong with the design here. We did a cohort study, and we showed about a 40% reduction. And then a bunch of trials came out. There were 4 here, but there are now 6. And they basically show about a 30 to 40% reduction in the risk of CP in offspring treated with mag sulfate. Mag sulfate is not a very expensive drug. The treatment lasts for 24 hours at most. And moms don't like it. It's true. It's not the best thing to give to moms. There are side effects, but still, these can be managed, and you have to be very careful about the use of it, but it has a tremendous benefit later. And these are kids born before 32 weeks, as I've told you, a very high risk of having cerebral palsy. And the remarkably consistent trials from the 7 trials of head body cooling with consistent reductions of 30 to 40% in the death rate, or 20 to 30%, I should say. And the disability, the pooled relative risk is 0.75, which means a 25% reduction in death. For disability, 73%, 0.73, a 27% reduction. These are very substantial effects for an intervention which is actually not that expensive. Unfortunately, it can't be done in small babies. The cooling is not tolerated well. Premature babies and cool weather don't go well together. They need warmth. But term babies do very well with this. It's just a 2-degree reduction for 72 hours, and we now have protocols to do it very easily in most hospitals. The other interventions prevent multiple disabilities. Rubella immunization. Kids with congenital rubella often have microcephaly, intellectual disability, hearing loss, vision loss, occasionally cerebral palsy. The folic acid story is quite wonderful. I'll show you something about it in a moment. But the trials have shown that, well, actually it's really one trial in this case, one big gigantic trial, showed a 60 to 70% reduction in the risk of neural tubes in high-risk mothers that had a a child with a neural tube or a pregnancy with a neural tube defect before by 60 to 70%. And with the neural tube defects, you have intellectual disability in about 15 to 20%, and 10% have cerebral palsy. There's some hints that folic acid may also do something to prevent cerebral ASD. I'll show you the papers here. The one at the bottom, Suren, Pal Suren, in Norway has shown that folic acid supplement use was associated with less autism spectrum disorder offspring in the Great Norwegian MOBA cohort. Iodine, very interesting topic, and leads to what is called endemic cretinism in the third world, and which is sometimes associated with cerebral palsy, always associated with severe intellectual disability and neurosensory hearing loss, and remains a big public health issue. Not sure why we can't get the iodine out to mothers, but we still don't. And a really interesting question remains in countries like ours, where iodine levels are dropping. People are taking in less iodine, using less iodized salt. Remember, salt is iodized. As it was a public health program, that's why we have it. And other sources of iodine. So, for example, in the US, urinary iodine excretion in women of childbearing ages is half of what it was 30 years ago. We wonder if that might make a difference, and we're actively studying this in Michigan, whether prenatal iodine is associated with any milder forms of developmental disability in offspring. So just to show you the great randomized trial, reduced it from 3.5% women who got folate to 1%, odds ratio of 0.28, a 72% reduction, and that we've also seen a very gratifying decline. In the US, we actually insist on putting folate in the flour. That's done in Canada too, but not in the UK. I don't know about Ireland. And that has raised folic acid levels in women, we know that, and we have fewer kids with neural tube defects. And this is the classic triad of endemic neurologic cretinism, Papua New Guinea, spastic diplegia, intellectual disability, sensory neural hearing loss. But whether we have something milder in the US and in Western countries, we don't know. This is completely preventable by iodine sufficiency. And what we do in these Peter Farrow's wonderful studies, you give an injection of iodized oil, and it lasts for 5 years. Give it before pregnancy, and bingo. This is eliminated by that treatment. It doesn't exist after that. So to summarize, we have lots of opportunities to prevent developmental disabilities, and the time to intervene from preconception to early childhood. And those of us who work in developmental disability should forge links with the other parts of the provider community, general practitioners, obstetricians, and pediatricians, to remind them of these opportunities to prevent. Thanks very much. Now, we're going to move on to the next presentation. I'm happy to tell you that we learned last night, well, that part I'm not happy to tell you. We learned last night that Orla Flanagan had an illness in the family that prevented her from coming. So Geraldine and I sat there panicked, and we said, now what do we do? So at the dinner last night at 8 o'clock, I came over to Keith English, our professor and chair of pediatrics and human development at Michigan State University, is attending here. And I said, can you pinch hit? Now, you're an infectious disease specialist, so autism diagnosis in the general community is not exactly his cup of tea, but nonetheless, and you'll understand that when I tell you a little about Keith, he immediately said, sure, I'll do it. I'll help you guys out. And he's going to talk to us a little bit about those aspects of autism prevention and early diagnosis in the community he knows about. And fortunately, we also have in the audience Tony Richtsmeyer from Grand Rapids, Michigan, also part of our university, who in the afternoon will join us. Tony is a developmental behavioral pediatrician, will in the afternoon workshop join us, and we'll further explore this theme. Now, Keith is an infectious disease physician, but since he's been at MSU for the last 5 years, he's been very interested and involved in prevention of developmental disabilities, working on the problems of developmental disabilities. He's chair of our internal advisory committee for CRAND. And he has worked to hire people in his department who are interested in autism and the developmental disabilities. And most importantly, in 2000, and why he's ready to just jump in 2009, some of you may know there was a very severe H1N1 new strain of flu in the United States, and it was affecting children very badly. And Tennessee, where Keith was before he came to us, was one of the most affected states. And Keith was basically tasked with suddenly, during an emergency, saving the day, organizing resources to deal with this health emergency, and was named Pediatrician of the Year in Tennessee for those efforts in 2011. So, 2009. So, welcome, Keith.
Thank you. Thanks for that kind introduction. I'm not an expert on autism and developmental disabilities, but I am someone who has been very interested in and concerned about these conditions really through my entire career, from my background and my interest in congenital infections, including congenital rubella and CMV, which I'll mention on one slide. But since moving to Michigan State University, now believe it or not, it's been 6 years, about a week ago, the major impact of our department, our major goal for expanding research in pediatrics has been in developmental neuroscience and autism and related disorders. And I'll call your attention to two posters that will be present today. Dan Campbell and Barbara Thompson are sitting in the back row up there, and they both have posters today. They're two of the first developmental neuroscientists who I recruited to Michigan State. Both of them study different aspects of autism. Dan's going to talk about the interaction between environmental risk factors like in air pollution from cars and brain development. Barbara's going to talk about social motivation in children with autism. So I think you'll see two examples of something we're doing in our department. I'm sorry to miss Dr. Flanagan's presentation, because I'm always trying to learn more about how we can do a better job to inform pediatricians and family physicians around the United States to be more comfortable with recognizing and dealing with autism spectrum disorder earlier than we do today. And in fact, in my role as a department chair, I'm very involved with both local and national efforts to do a better job of training future pediatricians in this area, something which I think will show up on one of my slides in a moment. So I'm going to talk about precision pediatrics and autism. So why do people talk about precision medicine or precision health? The term personalized medicine really went a bit out of favor, at least in the States, because it suggested something like in the Jetsons, where you go into the doctor, you stick something into the computer, and somebody spits out some medications or treatments just for you, or someone's sequencing your genome in their garage and they'll come up with some new medications to treat you. And that's not really where we are, at least for quite a while yet. Individualized medicine is something we've always tried to do, of course. We try to treat each patient and family as a unique situation. But precision medicine sort of became the preferred term because it meant we will tailor medical treatments to the individualized characteristics of each patient. And something that's not appreciated as much as it should be about precision health is the idea that not only will we try to find treatments and interventions that will help you, we'll try to avoid treatments and interventions that won't help you and might only harm you. Actually, the first successes in precision medicine probably are examples of that. Pharmacogenomics in the treatment of children with leukemia, for example, where we screen for a mutation that if it's present in 1 in 150 children, they'll have a terrible reaction to the normal dose of one of the chemotherapeutic agents we use, so we don't give them that. So it's hard to believe it was only 4.5 years ago when Barack Obama was president and said he was launching this new precision medicine initiative in the United States to bring us closer to curing diseases like cancer and diabetes. So why should precision health start with precision pediatrics? It's not just because children are more important than old people like me, although I think they are. It's because the roots of adult conditions and problems start before pregnancy, as Nigel pointed out, during pregnancy, in labor, in early infant life. That's where the roots of adult problems start. And if we're going to have a precision health future, it's going to have to start there. It can't start with identifying problems in 60-year-olds like me that then we deal with. The good news is the NIH agrees with this and thinks this is a good strategy. At least that's what they say, Nigel, on paper. Hopefully that's what they will do in the long run. The current funding priorities from the main part of the NIH that funds pediatric research, and there are many different agencies that do, but NICHD is the leading one. One of their priorities is to figure out how to catalog environmental and genetic factors that are the key to health. So that's a combination of the first two talks we heard today. And they focus particularly on developmental origins of health and disease and behavior and cognition. The new NICHD 2020 funding priorities were released yesterday, so I just made up these slides this morning. And they say that amongst the things that they will fund in the near future are efforts to understand the molecular, cellular, and structural basis of development, and they go on to talk quite a bit about neurodevelopment and the specifics, setting the foundation for healthy pregnancies and lifelong wellness. Here's what they say about development of neurodevelopment for their priorities. They say that if we're going to decrease the incidence of structural birth defects like neural tube defects, neurodevelopmental disorders, and intellectual and developmental disabilities, we need to improve our understanding of the origins of these conditions in the developmental process in order to identify potential targets and optimal timing for intervention. They go on to say, in order to do that, we'll have to characterize the genetic, molecular, and cellular events that determine how these cells develop and the pathways that form the nervous system. And this is important both for genetic and environmental risk factors because these are the pathways that are perturbed by environmental toxins. In order to do that, if we do that, the goal is to better understand early neurodevelopmental trajectories associated with health and disease so we can promote health and prevent disease, obviously. So, why does precision health need to focus on neurocognitive development? Everybody here knows that too many children here and everywhere in the world are at increased risk for problems with their neurocognitive development. And that's because for many reasons, including health disparities, where you're born, your zip code in the United States is a major factor in determining what your neurocognitive output will be. That shouldn't be. Adverse childhood events, genetic factors, infections, the one part of this I knew the most about before I became a chair, and environmental toxins. And of course, it's both nature and nurture. We don't need to argue, well, is it environmental, is it genetic, because it's both. It's more of one than the other, given a specific condition in an individual patient. But something I know a bit about and that I've had the misfortune to see a number of children severely impaired from congenital cytomegalovirus infection. This is the most common congenital infection in the United States and most of the world. And in the U.S., it's about 1 in 150 to 1 in 200 neonates, a bit higher in other parts of the world, a bit lower in a few places. Most of these newborns are asymptomatic at birth, but about 10 to 15% will develop hearing loss later. I'm ignoring right now the small percent of babies who are severely impaired at birth, who many of them go on to have severe neurocognitive disorders, including autism. By the way, rubella vaccine is arguably one of the strategies that's prevented the most cases of autism over the years, in that during the big outbreaks of congenital rubella syndrome, it was estimated that 30% or more of those babies who survived developed autism spectrum disorder in the long run. So ignoring the babies with severe disease, even the ones who look fine at birth that you would not recognize as being infected unless you screen for it, 10 to 15% of those babies eventually develop hearing loss. And so this is an environmental cause of hearing loss. It's the most common cause of acquired hearing loss in young children. But we don't know which 10 to 15% will develop hearing loss and which 80 or 85% will not. And the reason that some do and some don't almost certainly is based on small genetic differences between those babies. So people like Suresh Bopanna at the University of Alabama in Birmingham study this. They're trying to figure out if there is a genomic or epigenetic or metabolomic marker that would tell you which baby is going to develop hearing loss and which will not. Because the only treatment we have for congenital CMV infection today is a toxic medication with a lot of problems. We don't want to give that to every baby if they don't need it, but if it would prevent hearing loss, the risk might outweigh the risk might be outweighed by the benefit. All right, so let's talk for a few minutes then about autism and precision pediatrics. I'm going to mention the role of the pediatrician in making an earlier diagnosis, but because that's not my expertise, I'm going to ask Dr. Rixmeyer to tell us more about that this afternoon during the workshop. However, I'm going to talk about how research and basic research in autism might help us expand the list of ways that Nigel presented to us where we can recognize a child at risk for a developmental disability, in this case autism disorder, and how we might recognize that child and intervene earlier, or maybe even more specifically. Well, many of you are experts on autism, and you all know, and you've heard already, that autism is not one thing. It is not one condition. It's a group of complex disorders that share these key features, including the social interaction problems, communication problems, and may be characterized by these repetitive behaviors. Now, the heritability of autism is high. It's as high as 95% in some twin studies and around 80% overall if you average a bunch of large twin studies. So there's a large genetic component, and yet hundreds of genes are involved, and only a small percent of children with autism will be found to have a single gene mutation that might account for that, and many of those are in the syndromic forms of autism. So why do we need precision pediatrics in autism? Well, you've already heard we need to diagnose these infants earlier, diagnose them when they were infants, that would be great. We need to intervene earlier, and in the long run, we'd like to intervene specifically, and of course, we'd like to prevent autism when we could. So how about earlier diagnosis? You heard the numbers earlier. My data are from a year before that when the estimate from the CDC was 1 in 68. It's 1 in 59 now, but if you still count that category, it's somewhere around 1.5% of all kids. It's much more common in boys than girls, so it's about 2.5% of boys and about 0.5% of girls. And some recent estimates from, say, the family surveys suggest it might even be higher than that. And as you've also heard, most children who have a diagnosis of autism spectrum disorder have had concerns raised about their development well before their third birthday, well before the 1,000 days have elapsed. And yet the average time of diagnosis in the United States is at about 1,400 days of age, 3 years and 10 months. So we're not making the diagnosis early enough. In part because even though concerns have been raised, most of these children have not had a formal or comprehensive developmental evaluation by 3 years of age. Now here's an area, well, I'm not an expert, but I work with people who are experts, and the American Board of Pediatrics and the American Academy of Pediatrics have been trying to mobilize forces nationwide to do a better job of training future pediatricians and family physicians to know more about this topic, to be more capable of knowing when a child needs to be screened, referring appropriately, et cetera. So it's a big area, it's an important area, and we're trying to make some progress on that in the United States. We need to do better. And Tony can talk about that more this afternoon in the workshop. You've already heard about younger siblings of children with autism. Their rate of autism spectrum disorder is in the order of magnitude of 1 in 5 or 1 in 6, so it's high in 20% compared to that 1.5% in the general population. I was very happy to hear about the GEMMA cohort study that's ongoing here. That's great. We need more studies like that. The baby SIB studies that first started, Dan Goldowitz is in the top, in 2003 in Canada, I think, in collaboration with one group in the States. Now that's a coalition of 20 different centers around the world. There's a large cohort study out of UC Davis. Judy Vandewater is in the audience. So I think the more cohort studies we have, our ability will be greater to identify ways to make an earlier diagnosis, the way to recognize biomarkers or other markers. So this is great. So we definitely need to identify children earlier if we're going to intervene earlier. That's obvious. How will we do that? Well, there are a lot of different strategies, all of which might be helpful. We might be able to identify specific behaviors. We might have physiologic parameters like eye tracking. We might have high-resolution EEG or magnetoencephalography or other imaging that I'll talk about in a minute. Or we might have biomarkers. Interestingly enough, if you look for behaviors and you look closely and carefully in the younger siblings of children with autism, you find that a lot of them, in fact, in the largest study, the study first done in Canada, 40% of the children who were the younger siblings had some autism-like behaviors that were concerning to the investigators by 1 year of age, but by age 3, half of those kids did not meet autism criteria. So in fact, it was too sensitive and it wasn't very specific. And yet they often could identify early behavioral changes. Two of the most promising studies in terms of finding a verifiable marker of likelihood to develop autism, but of course not the sort of studies that could be scaled up for larger scale screening, are these two studies done from the University of North Carolina and the IBIS network that Joe Piven leads there. I recruited one of Joe Piven's faculty members as well to Grand Rapids, who studies the metabolome actually and neuroimaging, Rebecca Nickmeyer. But these two studies published in 2017 in Nature and Science Translational Medicine both found that either structural or functional MRI was quite good at predicting the autism diagnosis in younger siblings by the time they were only 6 to 12 months of age. The sensitivity was greater than 80% and the specificity was very good. Not perfect, but very good and better than any other test that's been done in these cohorts, and yet obviously we're not going to be able to do large-scale neuroimaging to screen kids. However, if the neuroimaging would allow us to correlate with some biomarker, of course that might provide a way to move forward. How about the maternal environment and earlier diagnosis of autism? Thanks to Judy for sharing some of her slides with me this morning. Judy Vandewater at UC Davis and the Mind Institute has been working on the maternal immune environment and the role it plays on fetal brain development. And she and her colleagues have shown that a maternal inflammatory environment alters neurodevelopment in the fetus, and that's in part because women who make autoantibodies may have children with a special form of autism that can be recognized, defined, and perhaps prevented. And we'll talk about more of that in the next slide. And of course, there's a precedent for this with other antibodies that have crossed the placenta and have caused disease in newborns. So, Judy, if I do justice to your slides here, let me know. I think Judy will be hopefully at our workshop this afternoon. So she defined this type of autism that she calls maternal autoantibody related, or MAR autism. It starts with knowing that women, particularly more than men, do develop autoantibodies to their own proteins. That's been known for a long time. We've also known that those autoantibodies can cross the placenta, but what she discovered was in a subset of children with autism, moms make autoantibodies that can cross the placenta and bind to antigens in the developing brain. She knows what some of those antigens are now. She's been studying this for probably close to a decade. She knows that that has effects on how neurons develop, and that remarkably, this accounts for up to a quarter of cases of autism spectrum disorder. Really quite remarkable. And these cases do have some distinct behavioral features. In general, the behaviors are more severe. There are more stereotypic behaviors, and it's associated with a larger brain volume in boys. And it's been known for a long time that a subset of children with autism, the boys have larger brain volumes. So interestingly enough, this is a common feature. So how about earlier intervention? I only have one slide here, but it's likely that the interventions that we have already that we know are helpful in many kids with autism, such as applied behavioral analysis, would probably work better if we could start them earlier. So even if we could identify younger siblings who are at risk earlier on, if we had nothing to offer other than what we have today, we think we'd have better outcomes. But of course, the holy grail of autism and precision medicine would be we could decide who has autism and perhaps why they have it, and that might lead to targeted or specific interventions. And of course, we'd also avoid interventions that were not going to help based on the specific mechanisms responsible. Trials of this are underway. They may or may not work. In the syndromic forms of autism, such as tuberous sclerosis and Rett syndrome, there's enough known about what the metabolic problem is, what the signaling pathway is that's abnormal. We have drugs that target those pathways. We'll see what happens with these studies in tuberous sclerosis disorder, where half of the kids develop autism. Rett syndrome is a terrible condition. If you've ever seen it, we know what the gene mutation is now. We know what happens in the developing brain. Small molecule inhibitors have been developed to try to treat Rett syndrome. We'll see if that works or not. If it works for conditions like that, it would certainly suggest there might be benefit for other children with autism down the road. And those might be children with or without a genetic mutation that we identify, but they might be children where there was a disordered signaling pathway or pathways that we could identify and we could develop specific treatments for. Whether the cause was mainly an environmental factor or genetic factor might not matter. And obviously, for maternal autoantibody-related autism, there's a potential we might recognize these moms at risk for having another baby before they're pregnant, and there might be a way to develop a specific intervention. I never thought this would work, but in some mouse models of genetic mutations associated with autism, correcting the gene defect reverses some of the neurological problems. I would have thought it was way too late for that to happen, and of course it won't work in every case. But there are some remarkable examples of benefit in these mouse models. This is my last slide. So the future of precision pediatrics and autism, I think, is we need to understand what goes awry in brain development that results in conditions like autism. And once we understand that, we can figure out how genetic and environmental factors might work together, and that ought to allow us to do earlier and more specific recognition, intervention, and even prevention in some cases. So that's the hope for the future. So I'll stop there.